yourself, please go ahead and do that to reduce the amount of feedback we might have with so many people in the meeting. Okay, so welcome. This is our June 2022 tag. Aside from muting yourself as you enter the room, if you haven't already, please revise your name in the meeting. So it's your name and also the organization you're representing today. That helps us keep track of who's who, not just us, but other folks in the meeting as well. Okay, next slide, please. Okay, so here's the agenda for today, largely decided by our group last month. So we'll do the usual agenda topics, a brief recap of the May meeting, a couple program updates, and the provider, a pretty broad provider organization agenda item. We've already provided a provider orientation webinar. This is going to briefly hit some of those points for folks that may not have seen that webinar. And if you haven't, all of those materials are posted to our website. There's a specific for provider organizations webpage, so please check that out. And then we're going to have a walkthrough of the data output slide our team has created for provider organizations. Most provider organizations on our list this year have yet to do their meetings with us. These meetings are optional, but we really strongly encourage provider organization staff to get into the process with OHA. So we're understanding how Cost Growth Target is looking at your data. And so we start to use and flex those Cost Growth Target muscles. All right. So this will be heavily provider organization focused. If you are here representing a payer, feel free to stay after the program updates. But if not, you're free to go, or you can look at this video recording when we post it later. All right, next slide, please. Okay, and next slide. So the May tag notes are posted to our webpage, so you can check that out if you have the time. The gist of what we did in that May meeting was walk through the final data submission documents. So earlier in the year, we discussed about changes to the data template, all relatively pretty minor, just a couple of tweaks to really tighten up the data submission this year. So, and then thanks to a lot of tag conversation, we added a couple bells and whistles to the final versions, especially to those data validation tabs to make technical staff able to read through those a little quickly. So we did a walkthrough of the final version of those documents, the template and the manual. We did have an affirmative decision to move certain low volume rows in the attributed tab over to the unattributed tab. These are rows that have 12 or less member months. Other things we covered are data submission events, such as the 2022 training webinar that was conducted earlier this month. The recording, the slide deck, everything is available on our website if you want to watch it again or watch it for the first time. Heads up, we do have a 2 summer office hours. One is on July 18th and one is on August 8th. So I don't think I attached those meeting invites to this tag to this June tag email, but I'll follow up with our data submitter contacts and send those again if you haven't gotten them already. So these office hours are just 1 hour where our staff will be on the line for any and all data submission questions. And also last month, we talked about what should we focus on for this tag meeting. Should we cancel it? Should we use the 2 hours since we do have it blocked off on people's schedules? And that's where we decided to go with a provider perspective and provider issues or questions. Next slide, please. Okay, so now a couple program updates. Next slide. So right after we had our May tag meeting, we officially validated all the 2021 data. So thank you to everybody involved on getting those data files in and corrected. Next slide, please. Yes. For whoever clapped. It was a big haul, even for data reporters who have submitted this type of data to other states. As you know, each state's cost growth target program can be a little bit different. And this was the first time for Oregon. So congratulations, hats off to all those people. We wanted to give a little bit of a summary of how our data validation went. So we had over 30 files to intake, process, and validate. That is by far the most files of any other state because the statute and the program for our state is very comprehensive. So everything is done. We officially have the statewide file as of the end of May. A couple stats, pretty much all the files needed at least one resubmission, which is totally normal getting the data. Well, only one file had a complete data file with their version 1 file, but most everybody needed at least a V2. I do have a little note here. 58% of files were able to pass with their V2 file. And then everybody else needed a little bit more. In terms of timing, over half of the files we were able to validate with everybody under 4 months. So that was a lot of back and forth, especially during the fall and holiday season. So we're really excited about that. In terms of how many member months were able to be attributed, I think we might have shared this already, but we're really excited that over about 60% of our member months in the state of Oregon were able to be attributed to a provider organization. So that's really great. Perhaps not so surprising considering, there is a lot of activity on this kind of operation in Oregon. I guess I'll pause and see if anybody from the Oregon Cost Growth Target team wants to add anything to this.
Hey, Trang, I want to share one comment on the 60% of member months being attributed. I think we've shared this in some individual conversations, but just to share with the whole group, we are really happy with that. Some data from Massachusetts and some other research on sort of attribution methodologies, they've only been able to attribute, somewhere between 20 and 30% of their member months. So again, we're really happy about how much of the data and information will be available at the provider organization level as well. So just to put that 60% in context, that is, almost double what we've seen in other states.
Yes, great. All right, let's go to the next slide. And I think I'll hand this off to Sarah, who's kind of taking the helm on these provider organization meetings we're conducting this summer.
Okay. So we shared in May that we were going to be meeting individually with all of the provider organizations. We sent out a notification letter to all 50-ish provider organizations that have been identified out of that master data file, the final statewide file. And we are working through the process of scheduling meetings. So some of the provider organizations on the call today have already had their meeting and seen their data output. Others, it's coming up in the next couple of weeks. So we will be working through these meetings throughout July, probably into August as well. We did do a provider orientation webinar, as Trang mentioned, that is available. We know there are some questions about from provider organizations about which other provider organizations are included, sort of who made the cut and who might be a comparable organization also having these conversations. There is a list of all of the provider organizations that have been identified for this initial cycle, and that's posted on our website as well if folks want to check that out. Anything else? Any questions or comments? Team, did I miss anything that we wanted to share about provider organization outreach?
No, I don't think so. I think that's it. And as we go through provider organization topics, maybe some other questions will pop up.
I just remembered two other things. So if your meeting has been scheduled and we have not had it yet, we're sending your data output and the agenda to you about a week in advance. So you will be receiving that from us on sort of a rolling basis as we're generating those data output files for you. And just to restate for the record, none of the data that we're sharing, none of the information that we're talking about in these individual provider organization review meetings will be published. We are not publishing the calendar year 18, 19, and 20 initial data at either the payer or the provider level. So this is just for information, data sharing, and validation purposes, but this will not be public. Thanks.
I'm on mute.
I think the next slide is me also, so I'll keep going. Durande, next slide, please. So we have been sharing the progress on getting our new Cost Growth Target Advisory Committee appointed and launched, and that is all happening. The first meeting of the Cost Growth Target Advisory Committee is this afternoon from 2 to 5 Pacific. So this is our kickoff meeting of the new committee. We'll be doing some grounding, reviewing cost growth target work at a national level, doing a lot of introductions, reviewing the charter, selecting co-chairs, thinking about group agreements. So a lot of committee housekeeping before we start diving into a lot of the content. But those meetings are public and you are all welcome to listen in. They will also be recorded and meeting summaries will be provided just like the TAG meetings. So just letting everyone know that that is happening. There will be several committee meetings this year. So the first meeting is today, the next meeting is July 19th, and we will keep you posted on conversations coming out of the advisory committee, especially as it relates to any technical details that we're reviewing in the TAG. Any questions or comments about the program updates?
Hi, Sarah, this is Daniel Porter. Will these meetings like this afternoon's be recorded and available?
Yes, there will be a recording of the video. These will all be virtual meetings, and we will also have a written meeting summary. So yes.
Great, thank you.
Any other questions or comments? Okay, Trang, back to you.
All right, thanks. Let's go to the next slide. I believe this is the same tentative schedule as we showed last month, just a breakdown of what we are anticipating to happen with regard to the advisory committee. Yeah, okay, let's go to the next slide and get into some provider organization topics. So right now we have a couple slides. This is basically a really condensed version of the provider orientation webinar. So please take a look at that if you want a little bit more detail. But as we go along through these slides, if you have questions, definitely use the chat or raise your hand, and we can, I guess, kind of talk about this as it's happening, and then we'll do the initial data output walkthrough. All right, so let's get into this overview. Next slide, please. And then the next one. So this is that provider orientation webinar we mentioned. The provider organization webpage has a couple different documents, slide deck, the recording. On that website is also the list of provider organizations that we detected, identified using that 2018 to 2020 data. That file also will give you some details about how our team used the file to find the provider organizations, because we did have to merge 30+ files. Also listed on that webpage is the provider organization notification letter that has just kind of different details. It's basically just all the same thing. All right. So that is your one-stop shop for provider organization stuff. Let's go to the next slide. So zooming out a little bit, what is a cost growth target? Looking overall, we're not going to get into the state of healthcare costs. That all of those topics are covered in the orientation webinar. But for this program that the state has created around a cost growth target, is because this is a shared statewide goal among multiple stakeholders in the healthcare system. This isn't a cap, this isn't rate setting or anything like that. This is a prospective target, an annual target per person for state healthcare spending among 3 markets, but we'll get into that later. So again, this is basically a growth rate. So allowing for growth, but making sure that the slope of that growth isn't too steep. And if it is steep, to have some conversations and figure out what is happening and to create some transparency around factors driving the steepness of that slope. Next slide, please. This program was established in 2019, and before the advisory committee, which Sarah mentioned, there was an implementation committee that was appointed by the governor, and there was a lot of conversation and decision making around recommendations to help shape what Oregon's cost growth target program would look like. And a big part of that is setting what the state target even is. So the target has been set for 10 years. We are in the left side of this graph, so you can see for the first 5 years, 2021 to 2025, the cost growth target is set at 3.4% positive growth. This number was informed by a couple different economic indicators, such as historical GDP and median wage for the state. A charge of the new governance committee, the advisory committee, is to revisit that target for 2026 to 2030. Right now, the target for those 5 years is set at 3%. Next slide, please. All right. You may have heard this in a lot of other presentations, but we have a statewide target, and it's going to be assessed at 4 different levels. We're going to look at the state overall, and then we're going to break it down by these 3 big markets, Medicaid, Medicare, and commercial. And then underneath that, we have the 2 entities, payers, health insurers, and provider organizations. Payers that are of a certain size and provider organizations that are of a certain size, you have to be big enough. You will have your spending assessed in each of those 3 markets. And we can, on the provider organization side, we can see how the data looks when we get to the data output later. Next slide, please. All right. So how do you figure out what organizations are going to be participating in this program? There's a lot of other detail about this in the webinar, but briefly, our state statute does direct the target to apply to all providers in the state. The implementation committee identified 2 criteria for inclusion to help winnow down that list. That, provider organizations that includes a lot of entities. So the first criteria is that these entities should be organizations that could be held accountable for total medical expenditures. You'll see the abbreviation TME in a lot of our documents, and that's what that stands for. And this is using a total cost of care approach. We have some 3 ways to attribute patients to provider organizations using a total cost of care approach. I won't get into that, but think of members choosing a primary care home. That's one way. Another way is that if there is a contract arrangement between a payer and a provider organization, that's another way. And then a third way is using that patient utilization data. So the second criteria is having sufficient patient volume. There's a lot of organizations, that they don't cover that many people. Another consideration we do have is to get enough data to be statistically confident of the spending trends. So having sufficient patient volume kind of it's not just a feasibility implementation consideration, it's also from a data confidence consideration as well. Next slide, please. So what does it mean to be included in this program? Oh, sorry, I forgot this one. I think this is pretty much the same material I've covered. If you want to learn a little bit more about how these criteria are applied, you could visit that link. That link is also, it'll take you to the list of 50 or so provider organizations that were identified using our first initial data set. But as you can see, this is just going over the attribution criteria. You could see some of those size thresholds there. So one way is having total covered lives across all markets over 100K, or having over 5,000 covered lives in one market. I think I said that right. Across all markets and then within one market. And when we have data conversations with provider organizations, we'll let you know how your organization was included into the cost growth target program. So that's, maybe we're talking about your commercial market and your Medicaid market. Maybe it's just one market, but you'll see the data outputs for all 3 markets if you have patients in those markets. Next slide, please.
Hey, Trang, we have a question in the chat about
Yes.
the geographic markets. And Eric, we are not measuring anything by geography. We're just looking at the line of business market. Is that what you're asking? Great, thanks.
Yeah. Another thing I'll note too is that when we're using the term provider entity or provider organization, we're talking about the highest level entity. So if there are medical groups, clinics that roll up into, you know, maybe a very large health system, that large mothership health system is the entity we're talking about. While we're paused here, do other folks from the data team want to add anything, Sam or Yishan?
No, Trey, I think you're doing great.
Yeah,
Okay.
doing great.
All right, thanks. Let's get to the next slide. Okay. So what does inclusion mean? So you showed up in the data if you're a provider organization. Your member month that were attributed to you were large enough to get scooped up in our program. Now what? So for this first year, as Sarah mentioned, we are not reporting any data at the payer level, nor at the provider organization level, but we are going to be having some data conversations, and that'll prep us for next year. So there is no public reporting. There are also no performance improvement plans or other accountability mechanisms like the financial penalties. None of that is happening. Those will be phased in, and we'll talk about that. You can see that phasing in the next slide.
Trang,
But
so we have another question. Can we pause for that?
Yeah, sure.
Blaine is asking if provider organizations are able to see how each patient was attributed given the 3 different attribution methods. So to clarify, we can provide more detailed information to each provider organization about how many member months were attributed by each of the different attribution methods, but because we're not using and receiving individual patient data, we can't look at an individual to see how any given person was attributed. We are able to, and we've shared this with both payers and providers in individual conversations, if there are specific questions about how a given payer has attributed member months to a provider organization, we can help facilitate additional conversations and potentially additional data sharing between the payer and the provider organization directly. But that's not a breakdown we can provide out of the data we have. Okay.
Yeah. Thanks. And we'll see, you can, when we go to the data output, you'll see where you can see that when your organization gets their data. Another thing to note when it comes to accountability, there's a lot of off ramps. So if the spending trends are over 3.4, because of the nature of the data and stuff, when they set up this program, statistical confidence was a big concern. So that's why we collect standard deviations. We have a whole statistical testing methodology we implement. So you won't be seeing that today with this data output. But starting with next year, you'll start to see some confidence intervals. So entities that last bullet, entities who have exceeded the target with statistical certainty and without an acceptable, reasonable explanation, only those entities would undergo a PIP process. That determination of reasonableness is what happens in our data conversations, the conversations between OHA and the provider organization. And we'll get to, practice that a little bit during these summer provider organization meetings. I think the organizations that have had meetings with OHA so far, they've been really great, and we've been able to talk about the data and sort of feel out and get used to what the whole process for that determination of reasonableness is going to look like. We don't have that process concretely fully fleshed out in rulemaking yet. That's going to occur next year. So keep an eye out for that. Any engagement with you folks will do a lot through these tag meetings. And Sarah, was there something?
Yep, I think we were just about to say the same thing. We do plan on bringing some more information back to the tag sometime between now and next summer, whether that's updates to the draft PIP process and template that we've previously shared. We'll also be having some of those conversations with the advisory committee this fall. We want to vet some of the materials and get some additional feedback before we go into rulemaking next summer. So not fully fleshed out, but we've got some starting pieces, and we'll be coming back to you all for feedback.
Is great. All right, let's go to the next slide.
And Eric is asking where we can find the draft PIP process. I will add the link in the chat. Eric, we shared some draft materials in a previous tag meeting. Ruth, the committee is not serving as the RAC. We will appoint and convene a formal RAC next year.
And that process will be a little bit new too, because of the
yeah. There are some new state regulations about how rulemaking and community engagement happens in rulemaking. And so we'll be convening a separate group, and it will have a really big focus on community representation and engagement as part of that convening.
Thanks. All right, well, on this slide, you can see the accountability phasing in. Essentially, what you want to look at are the last 3 rows, those bottom 3 rows. Are provider organizations identified in reporting? Do PIPs apply? Do performance improvement plans apply? And do financial penalties apply? So you can see at what we're calling our year 0, it's the initial data submission. None of those 3 applied. Starting with data that will be submitted this September, the report that is derived from that data will have provider organizations and payers identified, but there aren't going to be any PIPs, there aren't going to be any financial penalties. And then starting with next year, we'll have performance improvement plans applying. So we are just in year 1. Just to note, there is a little bit of a lag, so you'll also want to think in terms of when was the data submitted. So where we are, data submission in year 2022, we haven't received that data yet. So all of our conversations with provider organizations this summer, this is all on data that we have previously received. When we go and conduct our meetings with you next year, it will be maybe a little earlier in the spring because we're tightening that validation window. All right, let's go to the next slide. And we wanted to include this program cycle chart because I know, there's a lot of talk about data submission, and as an accountable entity, the things people, and for good reason, tend to hone in on are performance improvement plans, financial penalties, what's the target, which are all important components of the program. But we want to clarify and remind people this program is a lot more than just setting a target and assessing whether payer and provider entities meet that target. If you look at kind of the left-hand part of this wheel, you can see a lot of the action happens after we measure and report out the data. Reporting is, transparency number 1. We can't act on things we don't measure. So we're going to measure it first. And through our conversations with payers and provider organizations looking at their individual organization data, this is where we could start to kind of talk about opportunities to strategize how to move and row in the same direction in terms of getting a more sustainable cost growth in the state. A lot of the action in identify and implement will be, I think, you'll see a lot of that taken on by the advisory committee, which is, those meetings are open to the public. I think a lot of folks on this call, you might know people or have people from your own organizations that are members of the advisory committee. And this part of that left-hand part of the cycle is the really exciting part where we see our growth, we see the trend, what it looks like, and we all try to decide and work together to figure out what we're going to do. Did you want to add anything to that, Sarah, or other folks from the team?
Nope, you're good.
All right. And just to add one more note, the value-based, the VBP compact, the value-based payments compact group we have with the state, that is one of the strategies to attaining a sustainable cost growth target for the state. And I think probably many folks on this call may have heard of it or are signatories to that group. So that is great. All right, let's go to the next slide. Okay, and next slide, please. So probably what everybody's been waiting for. So now we're going to share a mock-up of the provider organization data layout output. These are the outputs that we are sending each of the 50 or so provider organizations that are large enough to be identified in that initial data submission. There's a couple things to keep in mind when you look at this data. A lot of them are in footnotes in this file, but some things to keep in mind I want to say verbally out loud is that these dollar amounts are unadjusted. As I've mentioned before, we haven't done any statistical confidence testing with this data. So when we look at, oh, the commercial trend is 5%, there are no confidence intervals around that 5%. So the interval, it may be very small and it is clearly over the 3.4%, or depending on the variation in the data, that confidence interval might be big enough to encompass 3.4%, in which case that 5% wouldn't lead to a PIP conversation. Another thing, well, we've mentioned this before, the data reporters, which are the payers, are attributing their members to the highest level provider organization. That granularity of data, which is not individual level, right? This is at the highest provider organization. That's the data OHA receives. When we get those files, we validate and then merge those 30 plus files and consolidate a huge statewide file and pick the organization from there. So you might have members from payer A, you might have patients from payer B, and we at the state see that, and so we merge that to get a member month count, a patient member month count for you. All right. I think those, yeah.
Can I add one more disclaimer, which maybe you're about to do on the next slide, but I really just want to clarify that this is fake data that we are about to show. This is not any one provider who's been de-identified. This is completely made up, as you will see from the nice, beautiful round numbers we're about to share.
Yes.
Please do not read too much into the actual values in this document. This is just to walk you through and get you familiar with the template.
Yes. I have highlighted and made a header on each page, but it certainly doesn't hurt to remind once again. Okay, it would probably be helpful if we started at the top. All right, I can't see what folks are seeing, so can someone tell me if this is large enough on your screen?
Hey,
I think it
Travis,
looks
it's
good.
Isha. Yeah,
Good.
it was good.
Okay, thanks. All right, so OHA, Sarah, or one of us is going to email your organization contact that we have to set up a data meeting. The email will also include this PDF attachment for reminding folks this is for incurred spending in calendar years 2018 through 2020. So yes, we will pick up the impact of COVID, and we can talk about that a little bit later. This is the cover page, so just make sure everything makes sense to you. We have been collecting feedback from provider organizations in their individual meetings about the order of these tables, other information OHA might be able to provide that would help provider organization staff better view this and get a handle of their spending. So as we're going through these tables, please give us feedback if you have them in the moment. If not, take it back, show your team. Feel free to email our email inbox with any feedback. All right, so this is what the cover page looks like. You'll have a date the data was compiled and a list of 5 tables. Before we get into the spending, we do want to sort of recap what and this is by member months, remember. So like one person who was your patient for the whole year and is attributed to you, they would show up as 12 member months. Right, so in tables 1 and table 2, we want to give you a snapshot of what your patient population looks like. This won't be really exact due to, we're looking at member months. We're also looking at payers attributing patients to you. Another thing to remember is that these are patients who are attributed to your organization and who the payer is their primary insurer. So there's a lot of people that this data doesn't capture. We're not capturing Medicare fee-for-service folks. We do get that spending, but it's going to be at the state and market level. Other things like VA spending, our program will receive at the state and market level, but not at this provider and payer level. So just keep that in mind. You may have a large Medicare fee-for-service population, and so your Medicare market may look low, but just know that it's because those people aren't there. All right, so we're going to show you your member month breakdown, and really here we're looking, we're asking you to look at these numbers and kind of ballpark, okay, in our data, it looks like you're mostly commercial or you're mostly Medicare, which would be Medicare Advantage in this file. Does that look all right to you? Those kinds of questions. We will show you member months by line of business and payer, so you can kind of see what payer is contributing the most people to your file. And then we get into the total medical expense summary. If you want to go straight to those trends by those 3 markets, table 3 is what you want to look at. But we'll go through that in a little bit. If after looking at the trends, something looks interesting, then we will go to table 4, and that's going to break down the spending by service category. And then lastly, table 5, we have a list of TINs that are associated with your organization. And that's kind of the one little bit of homework we ask of you to review that the TINs make sense, because those were the organizations that we received from payers and that we're using to compile your makeup. Okay, so this is an example of table 1. So just keep in mind these numbers are member months. So here we have a line of business, member months per year, and then over here we have a percentage of that line of business. So you can see in this organization, I think it was called Health System Z or something. We can see, let's look at commercial full claims. In 2018, they had about 500,000 member months attributed to them. It was over half of their patient pool, and it looks like Medicare Advantage and Medicaid were kind of evenly split, both around 22%. We do, yeah.
Sorry, go ahead.
I was gonna say, we are kind of splitting commercial partial claims from the commercial category. And we are splitting dual patients, dual member costs. So these, which are usually smaller member months, smaller patient pool, these are not you can see them here, but these are not going to be included in the market level assessment. So when we look at, is the spending trend over 3.4% for commercial, that is only for commercial full claims. These 3 rows.
And I want to take a step back again and just double down on something Trang said, which is that what we're going to be asking you to look at here is the ballpark. We know that because this is based on attributed member months, that this is not necessarily an exact match to your patient panels. We also are not including any data for folks who are uninsured. There's no data source for that. And so if you have a good chunk of your patient population who is uninsured or who is self-insured through a smaller self-insured entity, that data is not going to be here. And so we're not expecting these to line up exactly. And when you're thinking about validation, we're looking for ballpark and general direction of this. So if you know, for example, that you had a major swing and all of a sudden you now are serving many more Medicaid members, in a certain year, we would expect to see that same trend, but not, again, the exact values. If there are any nuances or weirdness or things to note about the data that we're receiving, we are trying to document that. So you'll see a note here. This measurement period crossed the CCO 2.0 transition. And so some CCOs are no longer in operation or CCO service areas changed, and we don't necessarily have data for all of that. So in some cases, we will point out to you things that we think are concerning or that we want to sort of hand wave in the data because we know there's an underlying data issue. We'll try to make that clear for you coming into the meeting. But we have been dumping a lot of information on you all. Should we stop here and see if there are any questions about the member months? Okay, maybe not. So one of the questions that we've had from provider meetings that we've had so far, immediately on looking at table 1, it's, well, who are the payers? Who is contributing these member months? Where did they come from? And so that's an easy transition down to table 2. Go ahead, Trang.
Okay, so on table 2, now we're looking at these 3 lines of business. So we're not looking at duals, we're not looking at commercial partial claims. Now we're looking at data that would be used to assess an entity's spending trend. So in Medicare Advantage, Medicaid, and commercial, you can see this health system, or I think it's a whatever this provider entity is. You can see they see folks, they have people in all 3 markets. This column payer, you can see what payer is contributing folks to your file. So over in Medicare Advantage, we have Health Plan A, Insurance Company B. You'll be able to see the member months for each of those payers. And here are your totals. These are the numbers we saw in table 3. And this is how they break down by payer. Over on the right side, this percent, this is just showing that, oh, in 2018, it looks like the member months between those 2 payers were evenly split. In 2019, it looks like Health Insurance Company B had a little bit more people than Health Plan A, but you could always go back to these member month figures to see if there are any changes within a payer. And kind of, as we mentioned before in table 1, we're looking for your review of this. Let us know if there's anything like really big that looks amiss. So if
I will
yeah.
add one more nuance that's popped up. So some of the conversations we've had with provider organizations, we've said, is there a payer that you contract with or that you would expect to see here that you're not? And there are a couple of places where, for example, a provider organization has said, I serve a lot of Kaiser patients, and Kaiser is not showing up here as a payer on this list. And there will be some nuance in that because of how some of the payers are doing their attribution. So some payers have attributed all of their members or many of their members to other organizations, and they're not necessarily showing up for you as a provider organization, even though you might be seeing them. They've been attributed through one of the 3 attribution methodologies to a different provider organization. So not to pick on Kaiser, but for example, almost all Kaiser members have a Kaiser medical home, and they've all been attributed to Kaiser provider organization. Even if you are serving them as a patient, it's unlikely that you would see Kaiser as a payer in your attributed member month. So there is a little bit of nuance here, but we will, as Chang say, be asking you, like, does anything look weird? Are there any payers that you would expect to see here that you're not? Are there any payers that you see here that shouldn't be here? And we'll go from there.
Perfect. That's great. That's basically the remaining things I wanted to say about this slide.
Sorry, we did not coordinate this as well as we could have.
I think that's okay. All right. So, all right. So now, also another thing, we've sort of mentioned this before. If there are questions you have about the patients you see and the members of a payer, and you'd like to know a little bit more about how a payer is doing that attribution, we, OHA, our program, we can help facilitate those conversations. As we noted, when we receive these files, it is at an aggregated level, so we do not get any patient level data, claims level data, none of that. The data we get is aggregated. So any of those more granular questions, we can go straight to the source. And by looking at which payer is providing, maybe the bulk of member months in one of your markets, we can see who that entity is. Right. I'll just roll along. Now we're going to table 3. which is very exciting because this is the table that will give you a snapshot of your entity's spending trend by market. So we can see for this provider organization, well, first I'm going to ignore the all lines of business below, so I'll scroll up a little bit. So I'm only going to be looking at these 3 markets because these are the 3 different trends we're interested in. In this first data submission, we got 3 years of data. So that means we received 2 trends, the trend from 2018 to 2019 and 2019 to 2020. Because we were in a worldwide pandemic, which greatly influenced healthcare utilization and spending, we've been handling the 19 to 20 trend as, okay, we need to see what it looks like. We want to see what it looks like, but we're not going to spend a lot of time or energy on it because we know the trend from 19 to 20 is going to be so weird. Likewise, we know that the trend from 2020 to 2021 is going to look really funky too. So for the purposes of looking at this data output and the data years we collected, let's just look at 18 to 19. You can see there rows in gray that will tell you your, here's that TME acronym again, total medical expense per member per month. You can see the trend in 18 to 19 in Medicare is over 9%, which is over the cost growth target for this organization. The trend in Medicare is, wow, very high, 24%. Well over the 3.4 state target. And in commercial, we also have another high trend, 15%. As we said before, this program looks at the trend. We're indirectly, I guess, kind of looking at the per member per month, but only to the degree that 1 year will feed into another year. So always, I think everybody always wants to look at these numbers, but this is the number we are directly interested in, and to figure out, why we got a 9, we'll go back here. So there was an increase in the per member per month. If you look at these rows above, you can see that most of the costs are claims expenses. It's pretty much, this is pretty much the same direction with a lot of entities. Most of the dollars contributing to your per member per month are going to be claims expenses per member per month, but you can see the proportions in these 2 rows. And in the row above in that market, you can also see a snapshot of your member month. All right. Let's go to the next table. There have been, looking at member month, I will say we've already had conversations with provider organizations, with payers too, where we'll see a huge increase or a huge decrease in member months in 1 year. And so we've already been able to kind of talk about that. Maybe there was a shift in business operations, or you took on patients that maybe had a different acuity. So I guess when we're looking at this data, yeah, it's like we're looking at little clues that will help us talk about reasons why the spending looks the way they do, looks the way it does.
One thing that's the kind of thing that's really helpful, just sort of contextual information to bring to these conversations, because we're looking at provider organizations at that highest level, the system level, that roll up. If your organization expanded, so say your organization acquired a new practice or merged with another medical group, and so now there's sort of multiple organizations or practices that are now included in one year and that weren't in another year, that is an easy explanation for some of the changes in member months. And those are the kinds of pieces of information that we don't necessarily have coming into the conversation with you. And we might say, hey, it looks like your commercial member months tripled between 18 and 19. What happened? And the answer might be very straightforward. You might say, oh, well, we acquired this other group and now they're part of our organization. So those are the kinds of things that we'll be asking you about. But again, I think as I said in the chat to Eric's question, we're not asking you to necessarily prepare any data or any rationale or documentation in advance. We'll send you this information, and when we meet, we'll talk through and flag things that we think look interesting or where there might be a potential explanation. And some of these things you might know off the top of your head. Some of these things might be very straightforward, and others you might want to ask more questions about or dig into either on our side or on your side. We're really viewing this, just in case it hasn't come across clearly, we're really viewing this as an iterative conversation, and as Trang said, looking for some clues and context as to what's going on.
All right, so that is table 3, wonderful table 3, where you will see your by market growth rate. So when we see something interesting, you see, this claims and non-claims breakdown, and you're probably wondering, oh, well, can we get into any level beyond this? Yes, we can. And we can do that in table 4. So table 4 will, again, we're going to split the spending into claims categories and non-claims categories. So again, so we're looking at Medicare. If you look at, it's a big table to look at, but if you zoom out, we have this dark gray line. This is the same information as table 3. So here's that 9.4%. If we want to dive a little deeper, hey, like what are the categories that are growing? Let's look at these light gray rows. So this is the information that was also in table 3. We have our claims per member per month and our non-claims per member per month. You can see the labels above the gray claims bar. These are our, I believe, 9 claims service categories. I'm not going to read each of them out loud, but you can see how we're categorizing these dollars. When data reporters submit the data file to OHA, they're submitting them to us at these breakout categories. We validate and then compile all of those dollars to give you a final this final number here for the claims portion of expenses.
One thing that I would add here is that we are providing all of the detail and the percent change, but we are not expecting that every single category and subcategory here in the future or even in this data would be below the cost growth target. So that cost growth target is just a reference point, but there's no expectation that every single category, subcategory. We had a question with the provider group this week about, well, does that mean that every single contract I have with a payer needs to be reviewed and come in under the cost growth target? That is not the level of detail. As Trang said, we're really looking at that gray bar, the TME total percent change, but we're providing all of this for reference. And one thing that I think is really helpful about looking at this, these subcategories, is looking at both where we're seeing high percent change, so high growth, but also high dollar amounts. So there are some of these categories where you might see a giant percent change, might be over 100% growth, but it's actually pennies on the dollar. And so where we want to really focus this conversation is understanding the cost growth drivers. So it might be that we say, yes, there was a large growth in a lot of these categories, but that's actually not that meaningful. We're still talking about less than $2 PMPM. Maybe let's focus on some of these larger, more expensive categories from a PMPM perspective. The other thing to note about this is, and many of you have brought this up in your conversations already with us, is that not all growth is bad. Oregon has initiatives where we want to encourage primary care spending. We have a primary care spending target. Oregon doesn't have, but other states have, a behavioral health spending target. So if we see a lot of growth in some of these categories, that's not necessarily a bad thing. And we want to recognize that there are additional policy initiatives and priorities around increasing spending and increasing services in some of these areas. So again, we're just providing this breakout for context and to help understand maybe where we want to dig a little deeper, not that it's an automatic, everything must be below the cost growth target 3.4% or else.
That's perfect. So as Sarah mentioned, when you look at this 18 to 19 trend, you could look at within the service categories, you could see who's growing really fast, what service category is growing really fast versus others. And how we've been reading these outputs with provider organizations is you could look at these first. Let's look at this one. Wow, 30% growth. As Sarah said, not necessarily bad, but this is what we're seeing is this was had a very high growth rate from 18 to 2019. And if you look at what it is, it's claims the professional other category. And if you look at the actual dollar amount, $10, it's a high growth rate area. So that's interesting. But in terms of how much this category is contributing to the bottom line, the claims PMPM, it's not that much. So this is where you'll kind of see your high cost categories. Again, this is a per member per month view of spending. So what we can see here is, hospital inpatient, the highest PMPM, hospital outpatient, retail pharmacy, and then professional specialty, and then you could see their growth rates over here. So as Sarah mentioned before, we're not measuring this growth at all against the target. Again, we're looking at that 9%. If that 9% next year, with the confidence intervals, if it's clearly above 3.4, this is where we could start digging in the data with you, and then maybe a dominant payer that is providing this data and is the primary payer for Medicare Advantage folks that you see. Yeah, Sarah?
Yeah, let's stop here for some questions. We've got one in the chat from Eric about breaking out emergency department versus other hospital outpatient spend. And I want to say that the answer is no, that the data from the payers is not being submitted in a way that would support that breakout, but I want to confirm that with the team.
That's correct. Well, I just want to add, we're not looking at any APAC data in here, but part of the cost growth target program's operations is using data assembled in this total cost of care manner, looking at what needs to be, like what deserves diving into, and then going over to our state claims database and digging in using claims data. We're not going to be using APAC data or talking about APAC data in these provider organization meetings, but just know this is going to be using both data sets are going to be a huge part of this program.
And again, as we shared earlier, it may be that some payer and provider organizations already have relationships and data sharing agreements, especially where there are total cost of care contracts in place, or there might already be data feeds or other ways to look at some of this in more detail, and we want to support that. So for example, if you're looking at this and you say, wow, my hospital outpatient spend is really high for commercial, and then you go up and you look at who your largest payers are in the attributed member months, that might help narrow down where some follow-up conversations could happen, and where some of that additional data could be provided, although it's not going to be a direct breakout or drill down of this data. Other questions or comments about any of this so far?
And maybe if there's any comments from Sam or Yishan.
No, I don't have any. Thanks.
Okay. Oh,
Sorry, I got stuck on mute. We have a question from Ada about non-claims payments via capitation broken down by service category. So the non-claims, essentially capitation payments are in that first row, the prospective payment category. In terms of being broken down by service category, essentially sort of an encounter-based proxy, we don't have that. That could be a really good conversation or place to dig into between payers and providers in the future. I think, again, Oregon is supporting a move towards advanced value-based payment models where we would expect to see continued growth in this non-claims prospective payment category as more dollars are shifted there. I think as more dollars are shifted there, it'll be important to make sure we have some insight into what's actually happening. But that's, again, not something that's directly supported by the data template that the payers are providing. That would have to be some supplemental analysis. Ada, does that, I mean, I know you're coming to this from a payer perspective, so does that make sense?
Yeah, it does. I just wanted to make sure we look at this from a PMPM perspective internally as well, but at the capitation level, we can see the type of provider and the services they would fall within to know if it's like inpatient hospital. Not a great example because we don't capitate a lot of services there, but if we did, we could see the number of claims, the number of member months, and is there a reduction per member per month overall because of that agreement, even though the cost is still there through capitation. But to make sure capitation isn't costing us more in the long run than just providing the payment on the service at fee for service. So
exactly. And I think that's a great example of the kind of data and the kind of additional conversation that could be facilitated or could happen between a payer and a provider organization directly. What are you seeing in that breakdown for those specific attributed lives? I actually want to pause. I know there are some provider organization folks on the call who have already had their meeting with us. Would any of you like to comment, especially if you've had a few more days now post-meeting to sit with this data? Anything else that you would share maybe with your peers about reviewing this data? Maybe not. Okay. Other questions?
oh, am I not sharing anymore? I think.
You stopped sharing. I think come back and let's go to the tins.
Yeah. So this is just looking at the claims breakdown, the non-claims breakdown, these categories in the Medicare line of business. So for this hypothetical provider organization, they have a Medicare table. Here's their Medicaid table. And then here's their commercial table. It's the tables are replicated market to market, so we won't go through those. Here's all lines of business combined, if you want to see that. The last table in this output is going to be a list of TINs and provider organization names that we have rolled up into your provider organization level. So remember, we collected multiple payer data files. A part of the data submission was to provide the state the provider entity name and any associated TINs, because that is what our program is using to kind of make our own kind of mini provider system directory. And we want to share the data that is being assembled underneath your provider organization. And we ask that you review this table 5, review these list of TINs to make sure that it makes sense. Also, if there are other TINs for groups or facilities that you know ought to be housed underneath your provider organization, this is a chance to see if they're included. If they're not included, please let us know via email or in the meeting, and we can add that to our state list. If we need to, we can also revise your output with the initial data if it turns out we were missing something, or maybe there was a TIN in here that shouldn't have been included. We can do that too and provide you with the new output.
And again, I think we've been framing this TIN conversation as homework. So you do not necessarily need to come into your provider meeting ready with answers for all of the TINs. If you have them, great. If you want to do a little prep work, that's great. But also it can happen after the meeting and be a follow-up, and we can refresh things. So again, we're trying to be really clear that we will walk through this in detail with you and your teams in the meeting, and then follow up after. You don't need to do a lot of prep or pull any data before our meeting.
Mm-hmm. And we have had instances where a provider organization staff knows that, you know, they recently acquired or merged with another group or clinic, and they've been able to bring that up in these conversations and give us the name of the organization and the TIN that should be included with theirs with the next submission. So that's really great. So already ramping up for the 2022 merged file.
And I will also add, I think for a couple of provider organizations, we have some specific questions about what we think is activity that's happened in this 18, 19, 20 period. So it looks like there are some organizations that might have been considered provider organizations individually, but then were included. And so we want to know, should they be included for this whole time period or not? So in some of your cases, we'll have some specific questions for you about who's being rolled up and if we're counting them correctly because of sort of your parent company or any affiliation or arrangement. So again, there's some nuance for a couple of you that we want to dig into. Questions about the TIN table and TIN review?
Okay.
Everyone's really quiet today, Trang. It's making me a little nervous.
If you do have questions, you can reach us by email, as always. And that brings us to the end of the data output. So I'm going to stop screen sharing. This is one of the attached documents to this tag meeting. So if you want to find it again, you'll find it on our CGT tag webpage. So I'll stop sharing, and Gerandi, can you share slide 24?
And while we're transitioning, I know some of our payers are still on the line. Now that you're seeing how the payer data has been merged and used to create the provider level output, do you have any questions or comments? I know this is a new walkthrough for you as well.
No comment from Don. This is Don from Providence Health.
And I will add, for those of you that are both payer and provider organizations, it's been incredibly helpful to have your payer data submitter team participate in the provider side conversations. So for those of you who did that, thank you so much. For those of you who are both payer and provider and your meeting is upcoming, we really appreciate having both sides of the house in this conversation. So thanks in advance.
All right. And I see your comment, Tracy. Thanks. All right. Well, so it's a lot to digest, especially for organizations that haven't had their meeting yet, which are most of the provider organizations. But after that kind of lengthy walkthrough of the data output, you saw those 5 tables. We wanted to hold some space for some, and we can screen share again if you want to look at a table we just went over, but we wanted to collect some feedback, maybe if there's any immediate thoughts on the output that we just walked through. Here are some questions that might spur a comment, like, do the table layouts make sense? Is the order of information appropriate? And is there anything else provider staff would like to see that we can include? And if you're not sure whether the CGT data can show you that information, I would say just go ahead and ask. We'll tell you if we can provide it, because if we can, we will. Okay. Well, that was a lot of information. If you would like to give us feedback, or if you would like to bring the data output to your team, we definitely encourage you to do that, and email us with any feedback or comments. Before we wrap up, aside from the data output, are there any other questions, maybe about the program overall? Any other questions that provider organization staff, if you'd like to ask them to us right now, we have a little bit of time in the last hour to answer them. Yes. So yep. Eric Schultz just asked in the chat, what file format is this output going to be delivered? And Sarah answered, it will be delivered in a PDF. And it will be attached. We will send it as an attachment in the email to your organization.
And I will say, and this is something we've talked about with the tag previously, in future years, when we do get to payer and provider level public reporting, we do intend to provide a public facing data book, some sort of Excel file that would include a lot of this detail in a more interactive way. So in the future, there will be some other ways to access this information after we go through this data review and validation. We're providing things in PDF now. I think feedback that might be helpful for us is if you'd like to see this in a different format, that would be good for us to know as we're thinking about templates for future years.
Okay, well, as you can see, we're on the last slide. Our July tag meeting is going to be Wednesday, July 27th. We're going to hold that meeting as a broad 2021 data submission Q&A. So if you're keeping track of all the data submission events, we have an office hours on July 18th, an office hours on August 8th. And you will have this tag meeting next month, which could also serve as an office hours, I guess. All right. And with that, that's the end of our June tag. As always, the schedule is posted at the end of the slide deck, so you can see where we are in the year and what's coming up ahead. Okay. And with that, I think we'll close for the day. Thank you all for joining us this month, and have a great start to your summer.
Thanks, Trang.
Thanks,
Sarah.
Thank you.
Bye.
Thank you.
Thank
Thank
you.
you.